Okay, I'll start then. That sounds great. So can everyone see these slides? And welcome to this session, which is called Perspectives on Local and Global Health, in which we're showcasing work by women and non-binary people at the London School of Hygiene and Tropical Medicine's new Data Science and Statistics Centre. So we have 4 speakers for this session, and they're each going to introduce themselves when they come to speak, and then talk for about 10 minutes on their use of data science and or statistics in health research that they're doing at the moment. And at the start, to kick us off, I'm also going to give a very short introduction to our university and the new data science centre that we've set up at the university. And then also at the end, after the last speaker, Em's going to provide some reflections on inclusion for non-binary people and women in our research. And then we hope to end with 5 or 10 minutes for questions. Without further ado, so I'm Poppy Mallinson. I'm an assistant professor at the London School of Hygiene and Tropical Medicine, and I work on non-communicable disease epidemiology, using various data science and statistical methods to answer questions about the epidemiology of mostly cardiovascular disease and diabetes in a range of settings globally. And I'm going to start to just introduce our institution and why we're what we're bringing to you today. So we're all based at the London School of Hygiene and Tropical Medicine, which is a leading postgraduate university in health sciences based in London. It's part of the University of London. And the London School of Hygiene and Tropical Medicine has recently launched a new centre for data and statistical science in health, which we call the DASH Centre. And what we're aiming to do in this centre is bring together data science and statistics experts and people with interest in methodology in these areas as applied to health research from across our university, but also beyond, and to generate new opportunities for research, training and knowledge exchange. And really, as sort of part of this, we're hoping to raise the profile of the sort of methodological innovation work we're doing in statistics and data science across the school. So just to give you a little bit more background into what we actually do, there's some core themes that the DASH Centre sort of revolves around. And these are routine data, which is using mostly electronic health records from different sources in different countries to understand the determinants and prevalence of health problems in a range of settings. Molecular and imaging data, which is to do with using mostly medical and bioinformatics data to improve our understanding of causes and predict the incidence of disease. Social science data, so that's particularly looking at qualitative data in relation to the health field. Data research, which is more about research in terms of how we collect data and how we can efficiently and effectively collect high quality data. And finally, statistical methodology, which is what it sounds like, obviously, but often applied to sort of use cases that we use in health research. And particularly today, the people that are going to be speaking are going to be related to this routine data and statistical methodology themes of the centre, but we also have work going on in all these areas. And in particular, we've sort of framed the centre around different health challenges that we're hoping to tackle. So one of them is improving environmental and planetary health. One of them is developing and evaluating interventions and diagnostics. One of them is understanding the major determinants of health. And then finally, it's informing health policies to improve population health and inequalities. So that's kind of what we're all about and what we do. And I know that not everyone at this conference is coming from a health lens. So hopefully it's interesting to see what statisticians and data scientists are doing from these different disciplines. Sorry, just to final word on the centre, there's ways to get involved, and we're really interested in interacting with people interested in statistical and data science for health, both from within, but also importantly outside our institution. And anyone's welcome to join our mailing list, where you can get a monthly newsletter with updates on some of the research findings that are coming out of our institution, some of the public seminars we're hosting, which are available for anyone to join online or in person, and also sometimes job and collaboration and training opportunities are circulated from either our institution or beyond. There's a link there which you can see to join the centre if you're interested. So that's a little shameless plug. But now, to sort of make this a bit more tangible, we're basically going to discuss or showcase some of the work from 4 members of the centre. And I'm going to go first just because it's easier that way. And I'm going to talk to you a bit about some of the work I've been doing with my team on artificial intelligence for low-cost assessment of chronic diseases, and some of the work we're doing in India on this theme. So the sort of background and motivation for this topic of this sort of line of research is that artificial intelligence has some really exciting potential to improve our ability to assess chronic diseases by automating the analysis of complex and high-dimensional data sets that previously were harder for us to analyze. And I think this has applications across research and also clinical care settings in health, but has also particular opportunities to provide benefit in low resource settings where we might be able to circumvent lack of resources or skills in certain areas, or make things more automated to improve equity and health outcomes, which is one of the things that our centre is about. And one of the other framings for this work is that there's a very high burden of cardiometabolic diseases, which includes heart disease, diabetes, hypertension, all these very common chronic conditions in India, and a fairly under-resourced healthcare system. So part of the work we're trying to do is think about how we can use AI to try and improve this. And the 4 examples that I'm going to be sharing, three examples, of ongoing work with our team that I'm going to be sharing is, first of all, some work around using very low-cost photographs of people just standing there in their clothes that we could use to classify obesity remotely, and trying to extend that as well to more hard-to-capture measures, I suppose, like body fat, mass, and also diabetes. Another piece of work that my team's been doing about classifying fatty liver disease using ultrasounds, but rather than having to go through a clinician to classify these scans, that we can do it automatically using deep learning. And finally, some exciting and very kind of upcoming work, so it's still in progress, that we're doing using thermal images of the feet to classify whether people are at risk of having a diabetic foot ulcer. And for all these pieces of work, we've got a similar sort of general workflow. So I'm just going to explain that very briefly now, and then show you the sort of results that we found from each example. So the basic workflow, which those of you familiar with machine learning and deep learning algorithm development, this might be very obvious to you, so hopefully bear with me if so. But is that we have a data set in which we have 2 measures, both measured. One is a kind of more expensive and harder to implement in low resource settings, what we're calling ground truth measure. So a more like high quality clinical measure that isn't always going to be available, but we have it measured in this data set. And then at the same time, on the same people, we have a sort of more low cost alternative measure that we've taken. So using this data set, which we've been collecting, and I'll explain about that in a moment, we split the data set randomly, mostly about 80%. Goes towards training to build models, and then about 20% for a held out test data set. That might depend on the application, how we split it. And then with the training data set, we use that, the ground truth and the low cost alternatives, to develop artificial intelligence and machine learning based algorithms, which can predict the ground truth labels from the low cost measures. And then we, using those algorithms, we apply them to the held out test data set to see how well they actually do on unseen data and generate performance metrics from those, which is what I'll be showing in some of the next slides. So that's broadly the sort of methods we've been taking for all these approaches. And in terms of the data source for these studies, we basically, my team and I have been involved in collecting data from a large longitudinal study, so a long-term study where we follow people over time, based in a rural area of southern India in Telangana state, which was set up by my team, some of my team members, in 2005, and we've just finished another round of data collection in 2023, so quite a long-term study. And the idea of this is basically to be able to see, by looking at the same people over time, how the risk of chronic diseases develops over time and what predictors might be. And most of the data I'm showing today is going to be coming from the most recent follow-up in 2022 to 23 of this study, which is called APCAP, sorry, I should say. You can see there the Andhra Pradesh Children and Parents Study. And in the most recent follow-up, we've been focusing on really trying to get as broad a range of high dimensional data as we can, so that we can do some of these AI-based studies and try and get insights into both assessment, but also understanding the causes of chronic diseases, which I'm not covering here. But this has included a whole range of different types of clinical assessment that we've done on these people, including doing ECG and cardiac and liver ultrasounds, body scans, and taking lots of videos and photos of different clinical parameters, like walking along like you would to assess frailty and gait, and also of the body, retinal images of the feet, and also various biomarkers, like some different omics studies that are underway. But again, I'm not going to talk about that all today, but this if anyone's interested, this data, we do share it, and it's available to share with the community, and we're hoping to do collaborations and work with people on it. So that's the data source. And there's about 4,000 people in total in the cohort right now, but the sample sizes for different studies vary a little bit depending on the data that we had available. So in the first example, we used body photographs to do obesity classification. This is work done with a master's student of mine, Katie, who's currently extending this to looking at body composition, more sort of detailed body composition outcomes in diabetes. And she essentially trained neural networks on data from 3,000 people to predict BMI categories from images such as these. As you can see, she's processed the images to take away the background to make it easier for the algorithm to focus on the relevant aspects. And the models that she developed were fairly accurate, as you can see in the confusion matrix there, at predicting in the held out test set the BMI category. And they were actually even more accurate when we looked at continuous BMI measures, but for ease, I'm kind of presenting this matrix here, especially accurate in discriminating people who are healthy versus obese. And it was a bit harder to tell the difference in the kind of middle categories, but this was a sort of first pass, and it's exciting to see this work developed. Some of the use cases of this might be, for example, a community health worker could just take a picture of someone rather than having to carry around scales and all the machines they might take to do risk screening for cardiometabolic diseases. And that could help to much more cheaply and quickly risk stratify people and get them into the right primary care pathways they need to be in. Second example here is, again, thinking about lower cost solutions to making clinical measures, both for research and clinical practice in low resource settings. And the idea here was that we had liver ultrasound scans, so taking an ultrasound of the liver, which is normally how we can diagnose fatty liver disease, but rather than having them graded by physicians, normally you need radiology physicians to grade these images, but instead could we get an AI algorithm to grade them instead? So we trained CNNs, again, convolutional neural networks, as deep learning algorithms on the ultrasound images, against the gold standard of clinician-graded fatty liver, using 3 clinicians who all graded and had to reach consensus on each image. This is work from my colleague Akshay, and he managed to achieve very high accuracy metrics, for example, an area under the curve of 0.9 on a held-out sample of test participants. And we also conducted a systematic review of everything else that's been, all the other work that's been done on liver ultrasounds, and we found similar, slightly lower areas under the curve in systematic review, most of which were from clinical populations. So we should have showed for the first time that in a community setting, especially in a low resource setting where the capturing of the clinical images might not be as high quality or as standardized, that we could get as good or better performances, which I think is really optimistic for actually changing this the practice in radiology here. So that was another example. And then finally, the third example, slightly different analysis here, but we started off by using an unsupervised clustering approach to understand whether we could see whether there were differences in people's in groups of people with diabetes in terms of how the thermal distribution of heat on their feet was. So if you can see these thermal images here, these are some examples of more extreme differences, but this left-hand image is looking like a sort of healthy foot, in the sense that the temperature distribution between the feet is quite even. And on the right-hand image, you can see a much more high-risk foot at risk of diabetic foot disorders on the basis that it has hotspots of temperature at different places, and it also has temperature asymmetry between the feet. And this is the kind of image that a clinician might be able to interpret to understand risk, but isn't normally used clinically right now. But given a lot of theoretical links between these temperature distributions and the inflammatory processes that we know are going on in diabetic foot disease, we thought it'd be quite interesting, just exploratory, to see what differences were. So we managed to generate 2 quite distinct clusters in the data using unsupervised clustering algorithms, and these strongly associated with clinical diabetes risk scores, like clinical neuropathy scores, peripheral artery disease, and diabetic foot ulcer risk scores. It kind of says to us that not only is this likely to be predictive of foot ulcer risk, but it also captures multiple different aspects of the pathology that's involved. Again, I'm not have time to get into the details of this, but if anyone's interested, obviously we have time for questions afterwards. And we're now planning studies to do prospective validation of this, where we actually classify build algorithms to classify people's risks and then follow up to see if we are able to successfully predict and prevent future diabetes foot complications from this. So that was my 3 examples. So I just want to say thank you for listening, and here's lots of the team members that have done all this work. So it's very much not just me, and it's a team based in London and based in India, and with lots of different partners and funders. So I'm going to hand over now to Emily for the next talk in our panel. Thank you, Emily.
Thanks, Poppy. So hi everyone, I'm Emily Granger. I'm a medical statistician at London School of Hygiene and Tropical Medicine, interested in causal inference methods. And today I'm going to talk about some research that I've done with various colleagues on target trial emulation in cystic fibrosis. Cystic fibrosis is an inherited, chronic, progressive condition caused by a genetic mutation that affects around 11,000 people in the UK. And it causes the body to produce this thick, sticky mucus, which can have a wide range of effects. It does primarily affect the lungs, but also liver, digestive system, and other parts of the body. Because there's lots of different symptoms as well, people with cystic fibrosis are usually on many different treatments, and this can take the form of medication, physiotherapy, nutrition, and exercise. Although recently these new CFTR modulators have been developed and made available for people with CF in the UK with certain genetic mutations. And they tackle the root cause of CF rather than the symptoms, so they can help with reducing multiple symptoms at once. So with the fact that people with CF are taking all these different treatments, there's a lot of questions around treatment effectiveness that are really important to the CF community. And typically, randomized control trials are used to assess the effects of treatments. But there's lots of high priority questions in cystic fibrosis about treatment effects that are challenging to investigate using randomized control trials. For example, what are the long-term effects of treatments? Cystic fibrosis is a lifelong condition, so people will be taking these treatments for several years, and randomized control trials tend to have shorter follow-up times. What are the effects of complex treatment strategies? So as I mentioned, many people with cystic fibrosis are on up to 10 treatments a day. And so the long-term effects of treatments used in combination or different ways of reducing the treatment burden are important for the CF community. And these can be difficult to address in randomized control trials because you will have so many different complicated treatment strategies to compare. Another example, what are the effects of alternative treatments in people who are ineligible or intolerant of CFTR modulators? So I mentioned these new treatments that have recently been introduced into the UK, but there's a small subgroup of the CF population who don't have the right genotype or are intolerant of these drugs. And so it's important to them to know what alternative treatments are available and how well they work. But because it's such a small group, again, it would be difficult to recruit sufficient numbers in a randomized control trial. So we need to think about different ways that we can tackle these types of questions in cystic fibrosis. And one alternative is to use target trial emulation with observational data. Target trial emulation is an approach where we use the study design principles of randomized control trials and mix that with an analysis appropriate for observational data. And we use observational data in the design. It involves 2 steps. So the first step, we describe our target trial. So this is an ideal trial that we would conduct if we could, that's designed to answer our question of interest, but this may be infeasible for one of the many reasons I spoke about before. So once we've designed that target trial, we think about how we can emulate it using existing readily available observational data. And going through this process can help clarify what your research question is and avoid unnecessary biases. Target trial emulation has become increasingly popular over the last 10 years, and in 2022 it was advocated as an approach for designing observational studies in the NICE real-world evidence framework. And there are lots of examples of target trial emulation across a wide range of diseases in the medical literature, but limited examples of cystic fibrosis. despite the fact that it could be used to address all of these important questions in cystic fibrosis that are challenging to address in trials. We also have access to a great data set in the UK for cystic fibrosis. The UK Cystic Fibrosis Registry is a national database managed by the Cystic Fibrosis Trust, and it collects data on almost all people with cystic fibrosis in the UK. People with cystic fibrosis will go to annual clinical review visits where their clinician will report data to the registry on clinical measurements such as their lung function, BMI, and various other variables over the past year, including treatment prescription, health complications, hospital admissions, etc. So I've been involved with the first 2 trial emulations to tackle questions on treatment effectiveness using the UK cystic fibrosis data, and I'm going to run through the first example today. So the question of interest was about people with cystic fibrosis related diabetes. This is a common complication of cystic fibrosis associated with worse clinical outcomes, and insulin is recommended as a treatment by international guidelines. But there isn't much clinical data to support the use of insulin, and little is known about the long-term outcomes of treatment. So the aims of this study was to compare the long-term impacts of insulin use versus non-use in CFRD. And we did this using target trial emulation and the UK CF registry data. The first step was to design this hypothetical target trial. So here we think about who would we include in the trial, what treatment strategies would they be assigned to, how long would we follow them for, and what's the outcomes of interest. We then think about how we can emulate this using the registry data. And there may be some differences here between your emulated and your target trial, depending on the data we have. So it might be that we don't have all of the data required to replicate the exact eligibility criteria, or perhaps the registry doesn't collect the outcome of interest, and so a proxy measure is needed. And it's important at this design stage to think about these differences carefully and the potential impact of those, but the idea is to get as close to the target trial as possible. One key difference that's always going to be the case between your emulated trial using observational data and your target trial is that in the emulated trial, participants are not randomly assigned to treatment strategy, so the analysis plan does need to account for confounding bias. These are the results from this paper. So this is looking at the mean difference in BMI between insulin users and non-users. The shaded region here is the 95% confidence interval. So as you can see, this contains 0 at all time points. So we didn't find any evidence of an effect of insulin use on BMI for use up to 1, 2, 3, 4, and 5 years. We also looked at subgroups, doing a subgroup analysis. So this is looking at the effects in subgroups defined by BMI status. Here again, we can see overall no evidence of an effect, but the point estimates are decreasing as BMI increases. So there is some suggestion here that insulin could be more beneficial for people with lower BMI to start off with. This is an example of a research question that would be unlikely to be addressed in trials because we studied long-term effects up to 5 years. And also we were able to do the subgroup analyses by people's BMI at baseline because we had a relatively large number of people in the registry who were eligible for the trial emulation. This would have been less likely in a trial because we typically wouldn't recruit as many people. For anyone who's interested, there's another example. The second trial emulation we did was looking at the effects of multiple treatments. So combined effects of 2 mucoactive nebulizers that are commonly used in cystic fibrosis. And this involved comparing multiple different treatment strategies. So it's another example of a question that's challenging in a randomized control trial, but we were able to address using trial emulation and registry data. One question that always comes up when we're using this type of data is how can we really trust the results? People do have a number of valid concerns. The primary one is about unmeasured confounding, but also there are concerns about missing data, measurement error, treatment adherence, etc. And one of the ways that we can get an answer to this is to benchmark existing trials. So here, instead of emulating a hypothetical trial that we've made up, we could try to emulate an existing trial that has been published and see if we can get the same results using registry data as were published in the randomized control trial. And this can help provide confidence that the results from similar studies using registry data would be reliable. There are lots of examples of this being done in other disease areas, but so far this has not been done in cystic fibrosis. But we have just been awarded some money from NIHR to start this, so it's a project that we're looking forward to starting very shortly. So watch this space. Okay, that's it from me. These are my acknowledgements, and thank you very much, everyone, for listening. And now I would just like to pass over to Dr. Orla Carroll.
Hi, everyone. So my name is Orla Carroll, and I'm a research fellow here at the London School of Hygiene and Tropical Medicine, and I work in medical statistics. And today I'll be presenting work on the exposure of syphilis during pregnancy and how this and the associations that this may have with childhood hospitalizations. And this is work that's been conducted alongside colleagues here within the SEEDS group at LSHTM, but also with Brazilian colleagues based at CDAX, NOVA, and CFET-MJ. So syphilis is a bacterial infection, which can be transmitted both sexually or vertically down from the mother to child during pregnancy. And it's endemic in both low and middle income countries. And Brazil itself has a considerable syphilis burden. But it's also, the rates overall worldwide are increasing over the last couple of years. And the short-term impacts of being born with syphilis are well documented. So you might have ocular abnormalities, hearing loss, bone damage, or higher mortality rates. But the effect of syphilis exposure during pregnancy for those who aren't born with congenital syphilis is unclear. And Brazil has a national population-based linked data set, which we used to compare the rates of all-cause hospitalization in children under 5 years. So using CDAX birth cohort data, which has been linked to disease notification data, hospitalization data, and mortality data, we looked at singleton live births between the 1st of January 2011 and the 31st of December 2015. Children were followed up until they reached either 5, the end of follow-up at the 31st of December 2018, or died. And the exposures that we were looking at were congenital syphilis, so being infected with syphilis during pregnancy and being born with syphilis, maternal syphilis, which we've defined as being infected during pregnancy but not being born with congenital syphilis, and then those who were not exposed. And we were looking at congenital versus those not exposed, maternal versus those not exposed, and any syphilis exposure, so either congenital or maternal syphilis exposure compared to those not exposed. And some of the outcomes that we looked at were time to first hospital admission, repeat hospital admissions, and also any of the ICD-10 codes that were associated with the first hospital admission. So for the time to first hospital admission, we looked at using a multivariable Cox proportional hazards model. And for the repeat hospital admissions, we used an Anderson-Gill model. And both of these models adjusted for syphilis, which used 2 binary indicators, one for having congenital syphilis and one for having maternal syphilis. And we adjusted for potential confounders, including the region of residence, the year of birth, age of the mother, relationship status of the mother's education, and also ethnicity. And for the first hospital admission causes, we've used Sankey plots to present these codes. So for those included in the study, we had about 8.3 million live births, of which about 36,000 were with congenital syphilis, 30,000 were with maternal syphilis, and the rest were not exposed. And in terms of baseline characteristics, we found that live births exposed to syphilis during pregnancy were more likely to be from Black, single, and less educated women than those who were not exposed. Of those with congenital syphilis, about 15.7% were born preterm, compared to 9.6% of maternal syphilis and about 9.5% of preterm births who were in the not exposed group. And similarly then, for those who were in congenital syphilis, we had about 16.9% who had a low birth weight, compared to 9.2% in the maternal syphilis group and 6.7% in the low birth weight. group are in the not exposed group. Interestingly as well, for those with congenital syphilis, they had a higher proportion of vaginal births compared to those with maternal syphilis or those who were not exposed. So in terms of time to first hospitalization, those with congenital syphilis, their time to first hospitalization tends to take around 0.1 month, compared to approximately 4 years for those with maternal syphilis and about up to just under 5 years then for those who are not exposed. And in the forest plot here, we see on the left-hand side, we have the two sort of panels which are related to the different models I was talking about earlier. So in the first hospitalization panel, this is from the Cox regression, and the second on repeated emissions is from the Anderson-Gill model. And we can see on the y-axis here, we have the different exposure of interest. So we have congenital syphilis versus not exposed. In the middle, we have maternal syphilis versus not exposed. And then at the bottom, we have any syphilis exposure versus not exposed. And on the x-axis, we then have the magnitude of the hazard ratio. And we can see here that any sort of exposure, whether it be congenital, maternal, or any syphilis, is associated with an increased hazard to first hospitalization, but also to repeat hospital admissions as well. And this sort of increased hazard was present within the first 36 months of life when we sort of looked further into how long these effects lasted for. But the strength of effect did decrease over time. And sensitivity analyses were conducted, which excluded preterm birth and low and high birth weights, but it didn't have any sort of change on the results. So these graphs are quite intense, but essentially this is a Sankey plot, which kind of just demonstrates the ICD-10 codes that were present within the first hospital admission. So on the left-hand Sankey plot here, we have the sort of records that were associated with congenital syphilis. And we can see that the majority or the largest proportion were related with infectious or parasitic ICD-10 codes, followed by the perinatal ICD-10 codes. And then similarly on the right-hand side, for the maternal syphilis Sankey plot, we can see that they were also, the highest prevalence came from the perinatal and the infectious and parasitic ICD-10 codes. However, for the not exposed group, the infectious parasitic didn't have the highest proportion. Instead, this was for the sort of respiratory and perinatal ICD-10 codes. So of the live births that did have congenital syphilis, about 55% had an ICD-10 code related to infectious or parasitic disease, which was compared to about 33% in the maternal syphilis and 17.7% in the not exposed. Whereas for the not exposed groups, their highest proportion tended to be related to the respiratory codes and the digestive codes. So to conclude, this was a population-based cohort study which included over 8 million live births, and we found that syphilis exposure was associated with increased morbidity and mortality risk and increased hazard for time to hospitalization. And the cause of these hospital admissions differed between groups, with any syphilis exposure having a higher percentage of perinatal ICD-10 codes than those in the not exposed group. And some strengths of this study is that it was a large data and the population, it was population representative, specifically for the comparison group as well. But some disadvantages or limitations include that because we were using administrative data, it means that we were lacking some clinical information which would have been useful for these types of analyses, such as HIV status. And we don't have access to all sort of confounders, so this can in turn bias our results, and additional issues could include potential misclassification within our exposure or missing data. Our findings highlight the need for close follow-up and careful monitoring of children exposed to syphilis, and highlight the need for public health action to not only reduce vertical transmission, but also to prevent the acquired syphilis in women of childbearing age before conception. I'll now pass over to my colleague, for her part of the...
Hi everyone. Thanks to everyone who's spoken before me. I'm the last speaker in this session. My name is Prestige. I'm a PhD student and research fellow here at the London School of Hygiene and Tropical Medicine. I've been at the school for 3 years now, and I'm just starting the second year of my PhD. And I'm going to have a bit more of a perspective talk. It's mostly planned work. I've not got results yet. So a bit different from what everyone else has spoken on. So I'm going to talk about modelling disparities in maternal RSV vaccines. My supervisors are listed on the slide, and also I've had some clinician input throughout the project so far. So some background on this particular project. It is part of my 3-year doctoral fellowship with NIHR, and it's the final objective in my PhD, but is informed by a descriptive analysis that I'm currently undertaking. It's a particularly timely investigation because maternal RSV immunisations are due to be rolled out this year. So some motivation for the project itself, respiratory syncytial virus or RSV, influenza and COVID-19 are common respiratory viruses which present very similarly and are hard to distinguish in primary care. They are all shown to be or suspected to be associated with non-white ethnicity and lower socioeconomic status. And vaccines for RSV are either under development or have been licensed for maternal and older adults. However, both non-white ethnicity and lower socioeconomic status are associated with lower vaccine uptake. For example, the maternal pertussis vaccine, 68% of white birth parents were vaccinated during pregnancy, whereas just under 62% of non-white birth parents were vaccinated. Therefore, when combining potential disparities in RSV burden, we could expect a maternal vaccination program to exacerbate the disparities should uptake also be varying. My PhD uses an electronic health records or EHR platform called Open Safely. This includes information on patient characteristics, diagnoses, tests performed, and medications prescribed. It does not include any free text from patient records, test results for secondary care, or dispensation of prescriptions. So any prescription information is just about clinician prescribing. The platform links patients via their NHS number to their hospital records, death certificates, and it is broadly representative of England. It covers 24 million people, which is roughly 45% of the English population. I can also link patients within Open Safely. For example, linking infants to their mothers to obtain maternal characteristics, or linking families via household information. However, this is a capture from 2020, and so is just represents household information at that point in time. So I'll just explain a little bit about the analysis I'm currently undertaking, which is a descriptive analysis looking at burden and disparities in burden of RSV, influenza, and COVID-19 across 7 seasonal cohorts starting in 2016, as this is when hospital linkage begins. The aim here is to compare disparities across age groups and determine whether these disparities are consistent for all 3 viruses. The age groups in question are infants, children and adolescents, adults and older adults, with a subgroup of infants who I can link to their mothers. This is roughly 20% of the Open Safely population. And this will then feed into my final objective, which looks at mathematically modelling maternal RSV vaccines. I will do this across all available data from 2016, and this will explore the impact of disparities in RSV vaccine uptake on the burden of RSV, which I've identified in my first analysis. The aim here is to look at the required uptake of maternal RSV vaccines to avert the worsening of disparities in RSV burden. This analysis will mainly be focused on infants, but we'll also look at older adults as they are another target group for vaccinations. I will start with the maternal vaccine modelling using a dynamic compartmental model. and then look at how ways that these discoveries can be mitigated by modelling different scenarios. This is a quick look at the model that I'm going to expand upon from Hodgson et al. I will be adding a transmission intensity parameter to this model to look at how household composition can impact transmission potential, such as living in multi-generational households, living in households with lots of sort of school-aged children, and look at how this can increase transmission rates. I will then go on to look at modelling vaccines in older populations, where I will use, again, a model from Hodgson et al., also including a parameter for transmission intensity. From these models, I will calculate expected RSV burden in the risk groups of interest. And then, as I said before, model different scenarios which I could use to mitigate this. It's important to also look at older adults, as uptake disparities exist in this population as well. In terms of possible extensions for this analysis, I can also potentially assess the rollout of vaccines now that they are beginning to be rolled out from this season, and I'll have data up until hopefully 2025. I should be able to look at the first year of the immunisation programmes. This won't be representative of the long-term patterns, but may provide insight into whether similar uptake issues are occurring with RSV vaccines as they do with flu and pertussis in the case of maternal immunisations. In terms of the impact of this work, the objective I'm currently working on will quantify the burden of RSV in England, which has not been done before. We've got quantifications of the burden in Scotland, but not broadly for England. I'll also be able to identify disparities within this burden, which has been looked at in the US and implied in some results in Scotland, but hasn't been explored thoroughly here in England. And then I'll be able to compare disparities between key respiratory viruses. This is particularly important because of the fact that there's a lot of effort being put into creating more equity within health outcomes for these viruses. And it's important to know whether these need to be tailored to the virus specifically, or whether a more broad approach can be taken to respiratory viruses as a whole. In terms of the final objective, what can be in terms of the impact, I'll be able to estimate the impact of differing uptake levels of maternal immunisation and older adult immunisation on existing disparities, and then make recommendations on how to mitigate these impacts, such as target uptake levels in certain groups. This will have influence on policy in early stages of immunisation programmes, which is important to avert the further entrenching of health gap disparities. And I'm just going to talk a bit about some opportunities for women and non-binary individuals at the school, mostly from my experience in the school as a non-binary person, but also opportunities available to wider members of both staff and student. So some opportunities include training opportunities, such as general leadership, negotiation, public speaking, and public engagement. I've personally attended negotiation training and public speaking training. These were particularly helpful, taking part in these trainings, which are aimed just at women and non-binary people, as it creates a safe space for us to discuss difficulties that we struggle with within the workplace relating to these issues that have a gender-specific lens on them. I am also aware of other training opportunities within different working groups. These were opportunities available to me as someone in my centre, which is the Centre for Mathematical Modelling of Infectious Diseases. We have a group within that centre for women and non-binary people that offers sort of training opportunities. In addition, there are opportunities for wider engagement within the institution, such as the Gender Equity Task Force, which works on not just involving women and non-binary people, but everyone across the school on increasing gender equity. We also regularly have school-wide surveys, so you can offer sort of feedback towards the institution and provide your view on sort of how you're experiencing the workplace. And as I mentioned, certain working groups have groups specific to women and non-binary people within them, so that you can create a network with each other and sort of create a support peer-to-peer. And finally, there are also regularly seminars for women and non-binary individuals within the school, both to attend exclusively, but also on gender-specific issues that everyone is welcome to attend. And I'll just quickly mention how LSHTM is a Working Families Employer member and a Bronze Award holder for Athena Swan. And the school also often reports sort of pay gap, not just for gender, but also ethnicity. So you can sort of track the trends within the institution. So that's the end of my talk, and we've left our contact information here. If anyone would like to get in touch to discuss our work or anything about DASH, please feel free. And also, again, here's the link for the external joining for DASH, which I think someone has put in the chat already. Thanks very much. And now we have some time for questions, if anyone has any. I think I saw one in the chat for Emily. Thanks very much.
Did you see that question, Emily? I think we could start with that one from Dorcas, who said, do you need to have access to target trial data for you to emulate it?
Yeah, thanks for the question, Dorcas. So quite often the idea is to emulate a hypothetical target trial. So this is not an existing trial with trial data. It's just in the first step, you design a hypothetical trial that you would like to conduct if it was possible, and then think about how best to emulate that using registry data that you have access to. So in this case, in a sense, the trial is made up. It's just the ideal that you're trying to copy using observational data. If you're emulating a existing trial, like I touched on at the end, which people refer to as benchmarking existing trials. In this case, it's useful to have access to the protocol so you can see in detail what they did and how best to emulate that. But I don't think you would necessarily, it might be useful to have access to the data, but really you just need the results to see if you can get the same results. Hopefully that answers your question.
Great, thank you. And please keep any other questions coming in the Q&A or the chat. I have a few questions that I've sort of thought about, so I can also carry on for a little bit. But yeah, just to give time for any other questions to come up that might come. So yeah, it's been great. We've heard from a range of kind of applied statistics and data scientists from both kind of local to us in the UK and also global health issues. And it's interesting that 3 of the talks were using routine electronic health data. So I wondered if the panelists would want to comment on the kind of pros and cons of that and why they think it's maybe interesting statistically from a statistical or data science perspective.
So I guess I'll go first. So in terms of routine health data, I think one of the benefits of there is that this data already technically exists. It's being regularly collected in the likes of hospitals, GPs, and with the size of it, it definitely allows for more sort of powerful statistical analyses to be conducted on it. And it's also making good use of data that already exists. We don't have to spend you have to spend money to access this for a lot of the time, but you don't have to spend money putting patients through potential medications such as you would in an RCT. And also because it's there, it means that we might be able to get some results much faster than what we could collect from an RCT to begin with, which might have longer follow-up required. So that would be my quick response to that.
I think what I would say is in terms of pros, I totally agree. I would also say that you can really explore rare conditions with these data sets because of their size and because you don't need to search out the people with these rare conditions. what I would say in terms of a con is that because they are not designed for research, the data quality can be inconsistent and really does depend on your data source. So I think that would be my take on routine data for analysis.
Oh, so I think those guys have summed it up well. I don't have anything to add, but I'm sorry. I was also reading the chat, and I just wanted to reply to Dorcas again that she said, does that mean you can define your own inclusion-exclusion criteria? And yes, you can in a hypothetical trial. Sorry, thank you.
Yeah, and there's another question in the chat there, which is, what are the next areas of research or topics that you'd like to collaborate on next? So maybe if each of you would like to have a go at that, or where you see this work developing.
So I guess one area that could be further developed for the work I was talking about with regards to syphilis is that for the maternal syphilis exposure that we're looking at, there is misclassification error in that. So we could see within the ICD-10 codes, Sankey plot for the maternal syphilis, that they did actually end up with some ICD-10 codes for congenital syphilis. And this could end up having, well, it would have an impact on the results that we presented. So further sort of work investigating that would be sort of the next steps, I guess, for that analysis.
I would quite like to get some access to testing data. So at the moment, the way I identify outcomes are through phenotypes I have designed to identify patients with those outcomes based either on diagnosis codes or on symptom presentations, depending on the sensitivity that I'm looking at. One thing I'd really like to do is validate these phenotypes with testing data, which hope is available through UKHSA, but isn't currently available in the data platform. So I hope that throughout at some point in my PhD, I will be able to do that to sort of look at how accurately I'm able to detect patients with these conditions.
One of the things I'm looking forward to doing next is this idea of benchmarking existing trials in cystic fibrosis. This is where we are looking at trying to replicate existing trials to see if we can get the same results in the first place as those trials. And then the next step would be to extend them to use methods to answer questions that, again, are unlikely to be done in trials. And it's one of the things that came up when on the first two trial emulations I did that I spoke about today, is that there are some different methodological approaches to using the UK CF registry data. So when we are looking at benchmarking existing trials in our next project, one of the things we'll be doing is comparing these different methodological approaches and just trying to find the best way of using the existing data. And thinking more broadly, we're hoping that these similar approaches can be then used in other disease areas with similar registry data sets.
Thank you. That's great. Thank you. I was going to quickly answer that myself. Sorry, I forgot. Yeah, so the work we're doing is quite interesting. We've got lots of these models developed for potentially either phenotyping or risk prediction clinically for low-cost ways to do this in low-resource settings. And the next step for us is really to work on the implementation. So there's a lot of, like, I guess, like in silico work with AI, but less kind of in clinic and in situ in settings. Can it be implemented? What about the technology challenges? What about the internet processing power? All these challenges, and how acceptable are they to people, to health systems? Do they actually improve workflows? So in a way, it's working with a lot more of an interdisciplinary team that includes sort of implementation scientists, clinicians, as well as data scientists like ourselves, to try and kind of move this into something more practical, which is really exciting. And we have some kind of grants submitted to try and do that, but we'll see if it happens. And then maybe we have time for one more question before allowing some handover to the next session. So I just had one question, which is a bit more broad as well for everyone. So I think a lot of the panelists today have been from statistical or mathematical backgrounds. So I'm interested in how women and non-binary people from statistical mathematical backgrounds found like a applied health area, and how did you sort of arrive at an area where you could apply those methods to sort of generate health impact like you're doing? Because yeah, it's interesting to see that there's such impactful work going on from people who are also methodologically trained.
I guess I'll start. So previously, I used to work on sort of target trial emulation for surgery interventions or also for diabetes medication. But I guess overall, I tend to read a lot of feminist literature in my free time, and women's health is definitely under-researched. So it was something I was definitely motivated to sort of switch over and across to. And luckily, I think for myself, my line manager, Annie Paisho Cruz, who works here at this school, was advertising a position that was looking into infectious disease exposures during pregnancy and how this can impact non-communicable outcomes for children. And it just seemed absolutely interesting, and that's how I switched over into kind of the area that I'm in now at the moment.
So well, I came from a maths background where I was originally sort of planning to be a teacher. And then when the pandemic happened, I really started looking more into how maths can be used for kind of modeling infectious diseases, and also kind of looking at medical statistics. And it was during my degree that I decided to do a sort of research project, my dissertation, on looking at kind of government policies' impact on transmission. And that's how I eventually found the school and did a medical statistics master's here, and just sort of stumbled into this relatively applied field, which I would say at my undergrad institution was not a field I was aware I could end up in. So that's how I ended up here. And I think it's interesting that within this field, the sort of gender balances sort of actually invert to when you come from a maths degree, which is a very interesting kind of phenomenon, I think.
Yeah, I want to agree with Em's comment just then. So I also come from a maths background. My undergrad was in maths, and I similarly found that the gender balance seemed to invert when I went more in towards medical statistics. Yeah, so towards the end of my undergrad, I was thinking about how I wanted to apply my degree to do some good, contribute well, and that's where my supervisor for my dissertations project kind of suggested doing a survival analysis on hip replacements, and that kind of got me into medical statistics. And then after that, I got an HR research methods fellowship, which is really useful for bringing people a bit more into the field. So that's kind of how I got into this. Thank you.
Brilliant, thanks so much. So I think that probably concludes our session, unless there's anything else anyone wanted to ask. But Cynthia, can I hand back over to you to kind of do the handover to the next session?
Yes, thank you very much. Thank you to all of our presenters.